I'm delighted to be here, and as you can probably gather already, this is not a New York accent. I have been in New York a long time, but I actually grew up in Ireland and went to New York as a 17-year-old. So when I'm in Ireland, I think I have a New York accent, and when I'm in New York, they think I have an Irish accent, so I'm not sure what people think here. But I've been listening yesterday and today, and I find a lot of the discussion fascinating. And I'm going to make some general comments. I'm going to be conscious of time because I know that they do keep strict time schedules here. So obviously we cannot cover all of the things that we would like to cover in a small period of time like this, but I'd like to make some comments. One is that I'm going to say something that at the beginning that I think might sound a little bit unexpected because there is so much doom and gloom around the place and around the world regarding healthcare and what's happening. I happen to think and believe firmly that this is an unbelievably exciting time to be in healthcare. I wouldn't want to be any place else at this period of time because at a period of time like this, it's especially exciting for those people who believe in change, who believe in not being hostage to precedent, who believe in pushing the edges of the envelope, who refuse to be prisoners of the past, and who basically believe, as I think every leader should, is to try to create the future. And in a room like this with such extraordinary individuals and leaders, this is what we should be all about, is irrespective of the outside pressures that are on us and irrespective of the circumstances that put emphasis on us, that we have an extraordinary ability to be able to change the way we do business. I firmly believe that. And I believe that austerity is here. It's going to be here for an awful long period of time. It's going to be here for the rest of our careers. So we have to be looking at how it is we maneuver through all of the austerity that we are currently facing and figure out how to deliver a better product, provide a better service, do things more innovatively than we've ever done before. Now, it's interesting in listening here at the discussion yesterday and today is that the issues are exactly the same in the United States. Very, very same discussions occur, just like you're having here. Obviously, the structure of the systems in the United States are different. There are good things happening in the United States. There are things in the United States that you would not want to emulate. But there are things in the United States, I think, that can be helpful, just like there are things being done here that can be helpful in the United States because we can all learn from each other all the time. So the issues in the United States that everybody's talking about these days, obviously, is about coverage. It's about getting better results, getting better value, how to keep costs under control, how to promote health, which I will come back to, as well as treat illness, because I believe that we primarily are in the illness business, and I don't believe we should be in the future. And also the discussion around balancing the role of government vis-a-vis the role of the private sector, balancing command and control versus entrepreneurship and innovation. These are the issues just in the United States that are being discussed as they are here. And in the United States, just one last comment on this, there is at the moment a lot of confusion. There are some organizations that are moving forward, that are leading, that are doing very, very innovative things. There are other organizations that are pretty catatonic. They're not exactly sure what to do because in the United States, as you know, we've got this whole big reform movement. There are major questions about whether a lot of the reforms that have been put in place will even work. Some of the expectations about some of those reform efforts, I believe, are greatly exaggerated. I don't believe they will accomplish half of what people say they will accomplish. Other people think it's the best thing that's ever occurred. So what the result is that some organizations are moving forward irrespective and doing some very interesting things. There is a blurring of the roles between providers and insurers. And there is major consolidations going on. Hospital systems are getting bigger. Physician groups are getting larger. Everybody's trying to position, which in many ways is quite interesting, and I think a lot of good things can come out of this. So let me just talk about one system, which is the one I have responsibility for. And so I'll give you a little bit of a description of the system and make some reference to some of the points that were made here over the last day and a half. And then I'm going to talk about some lessons that I have learned that I think might have applicability to the audience here. Because quite frankly, many of them have come up in the various forms of the discussion over the last day and a half while I've been sitting in the room here. The health system that I run is very, very large, as Julie mentioned. We're in the New York area. We cover the whole broad New York area. Obviously, we have competitors, which I think is good. We have very strong competitors, so if I fall asleep at a switch, my competitors, as I said, eat my lunch, and so I might try to make sure that they fall asleep at the switch so I can do something to them, and I think overall there is a benefit to this, and I can go back to that point in a little bit. But all of the hospitals that are now in our health system were once vicious competitors. They didn't like each other. Hospitals next to each other, they didn't get along. I'm sure you have nothing like that in the United Kingdom. But beginning in the 1990s, we decided that it would make an awful lot of sense to have a lot of these hospitals work together. So today we have a system that is a major clinical system. We have 16 hospitals, as Julie mentioned, 5 tertiary campuses, community hospitals, psychiatric hospitals, children's hospitals. But we also have, and the number is much larger than the number Julie was given, we have about 400 ambulatory locations. Our biggest part of our growth is in the ambulatory outpatient business. Some of my ambulatory sites are 300,000 to 400,000 square feet. These are like big hospitals without beds. We have long-term care facilities. So we have nursing homes, assisted living facilities, major home care. We are a big academic teaching center. We have one of the largest academic teaching entities in the United States with 1,400 residents and fellows. We have a medical school which we just opened about 1.5 years ago. 2 years ago. We have a major research entity. We're in the top 6% of research entities in the United States. And all of these pieces from acute, home, ambulatory, long-term care, all are completely, totally integrated. There is single leadership over it all. There's single medical leadership and clinical leadership, single administrative leadership, one board of trustees. I actually happen to be the CEO of each individual entity, as well as the CEO of the parent corporation. And that gets back to figuring out how you get something done at the various individual hospital and site levels, because the staff work at my pleasure. I have unions, but I make changes, and I'll come back to that point. So we have single leadership, single board, all back office functions are consolidated. One finance department, one central quality oversight, one facilities construction department, one contracting department, one procurement department. When we purchase goods and services, we purchase as one legal department, etc. All of these entities at once sat in each individual facility. They no longer are in those places. They're all centralized. So they're consolidated to the extent that we can consolidate. And obviously, when we look at consolidating things, we make sure that from an efficiency point of view, a cost kind of view, etc., it all works. We've consolidated services. So, for example, we have single clinical leadership over the whole arena or the whole area. So, for example, there's one chief cardiologist who oversees all cardiology, neuroscience person who oversees all neuroscience, OBGYN person who oversees all OBGYN, and on and on and on, like emergency medicine, etc. We've moved for services from facilities to facilities. We've consolidated cardiac services in certain places. We've closed OB services in some places. We have downsized some hospitals, and I'll come back to that point in a little bit later. So we look at the market, we look at the needs of the population in our area, and we make the decisions as where services should go, where services should not go, whether they should be in an ambulatory site or in a hospital. And I do believe that there is way too much hospital care, and I will come back to that as well. We have single metrics across the whole organization. One set of metrics. The metrics are on the quality first, service 2, and finance 3. The staff is held accountable based on performance payment for the quality metrics, the service metrics, and the financial metrics. And all of the leadership is held accountable to the same metrics, and that includes the physicians, the nurse leadership, and the administrative leadership. So they're all bound at the hip. I listened to some of the discussion here, and I got this sense, I could be wrong, of a little disconnect between the clinical and the administrative. In our system, it is was I right on this? In our system, it is completely combined. Nothing happens without the clinical leadership, the nursing leadership, and the administrative leadership being on the same page. No decision I ever make is done in total absence of the physician leadership and the nursing leadership. And that's the same at every single facility. Physician leadership performance, he's held accountable or she held accountable for the finances and the quality, just like the administrator and just like the nurse leader. So this is an unbelievably integrated system. So we also, by the way, just in case some people are thinking, we treat all patients, no exceptions, irrespective of whether they have insurance or not, because in the United States, as you know, some people don't have insurance. So we treat all patients, irrespective of condition, including government patients that are paid for by government, patients that have no insurance at all, we take care of. There is no distinction made with regard to this. So the point I want to make here, and I could describe this system in much greater detail, but it is the only true integrated system in the East Coast United States. There are others in other parts of the United States, but we are by far the most integrated. It has taken us 10 to 12 years to get to this point. It is not easy work. Does not mean you don't make enemies along the way or you don't have people pretty distraught about it, but at the end of the day, when the decision is made, I have found that those people who were once distraught are today very, very, very happy. People don't like change, but you've got to push it forward if you want to get to a different place. So the point I want to make, though, before I finish this little section, is that I don't just manage hospitals, even though people talk about us as a hospital system. The biggest part of our organization is non-hospitals. My goal is, over the next 5 years, is to have 70% of everything I do in terms of care delivery not be in a hospital. Today, we are about 50-50. I want to get to 70% non-hospital, 30% hospital. I agree with the comment that somebody made in the last panel that there's about 30 to 40% of people who are in hospitals today should not be there. The reason is that you don't create the alternatives. The benefit I have is I can create the alternatives. I have the ability to create the alternatives so people can be in other places. And the major focus of the health system on an ongoing basis is obviously performance. It's a major focus on consistent innovation and creativity. That's driven an awful lot by competition as well, because, as I said earlier, if I don't move fast, others will take my place. Others will gain market share over what I have got. We build for long-term sustainability. I spend most of my time focusing on 5 to 10 years out, rather than the day-to-day, month-to-month. Obviously, I stay very close to this. But I have my operating people who watch the day-to-day budgets. I'm very familiar with them, but that's their primary role. I primarily look to see what it is I want to be 5 years, 10 years from now. And for example, on April 5th, I present a 10-year plan to my board as to what I assume we're going to be and look like 10 years from now. And that's where I spend a lot of time looking forward. We invest a lot in, obviously, physical plant, IT, but a major, major investment, which I'll mention a little bit later on, is on staff. We have an extraordinary investment in the human capital and in the labor force within the organization, which is absolutely key. And we spend an extraordinary time building a culture of teamwork, transparency, commitment, innovation, passion, and caring. And some lessons. And let me just go through these relatively quickly, since I know we're getting short on time here. One, to me, is the importance of having a complete integrated system with all the pieces. I don't worry about if I reduce what happens in my hospitals, I build up what happens in my ambulatory side. If I think I have too many patients coming to the hospitals, I build alternative locations. I'm a strong, strong believer that you take the business out to where the customer is. Just before I left the United States, I signed a deal with CVS Pharmacy, which is the largest CVS largest pharmacy system in the United States, or one of the largest, where there's going to be a clinic-type service in every pharmacy overseen by our system, so that you don't have to come to an emergency department to get basic stuff, because so many people come to an emergency department without any need to be there at all, and they wait because the alternatives have been, short, and they just wait in emergency departments when they shouldn't be there. So you got to find other locations. It also allows the opportunity to create emergency departments that are not in hospitals, which we're building and have created. So the idea that an emergency department, full comprehensive emergency department, always has to be in a hospital doesn't seem to make an awful lot of sense. You can actually have them freestanding. We also have, by the way, if people are thinking, how do I get from one place to another? We have our own medical transport system. We have a very, very sophisticated medical transport system with 125 ambulances operating all the time, with our own command system, our own medical control, so we can move patients back and forth all over the place pretty seamlessly. We don't have to depend upon anybody else to do this. So having all of the pieces, I look at myself as a CEO of a continuum of health services, rather than just hospitals or ambulatory or home care. I've got all of the pieces. Therefore, you can organize care in a much more rational way. The second point I want to make is that overall performance and quality is in our organization everybody's business. The quality agenda is not just a department. It is not just sitting in the responsibility of the clinical leader. It is everybody's responsibility. I, for example, meet with every single new employee that is hired in the healthcare system. Every Monday morning, including this Monday when I go back, and I've been doing it every Monday for 10 years, I meet every single employee, from the person who parks the car, the person who washes the dishes, the person who cleans the floors, to the physician, to the nurse, all together. We hire 125 people a week. I meet every one of them. I spend 3 hours with them every Monday morning. One of the points I make in this regard, because I go through all of our metrics, our business imperatives, what we have to be successful at, I display our metrics, I display the goals with regard to our metrics, and I make a very, very strong point that the issue of quality is everybody's business, including the environmental worker who sits in the room. That environmental worker who cleans the floor, cleans the room, is a quality worker. They don't do it correctly, you have an infection, which we then would have to respond to later. You have a potential infection. So they have to see themselves as having a major, major role with regard to quality. Similarly, for example, the valet parkers, we have valet every place. The valet parkers who park the cars, I tell them they're service workers. They don't just park cars, they provide a service to the occupants of the car. And if you want to find out how patients are thinking about a hospital when they leave, go ask the valet parkers. They will tell you, which I do on a regular basis. As when people leave, if they're happy, they say so. If they're not, they grumble. And the people who meet with them and give them their vehicles, if they're out in an area where they all come by vehicles, then obviously you get a very good sense of what people are talking about. A third point is that we spend an extraordinary amount of time, and have succeeded in this, in building an interdisciplinary structure. This is that there is no silos. And it goes back to the point I mentioned at the beginning, where you have the physician, the administration, and the nurses completely together all the time. Every single meeting that goes on in our health system has all three in it. Once a month, we have a major performance improvement coordinating group, we call it, which is one of our major quality meetings. All the administrators from every place, all the nursing leaders from every place, and all the clinical leaders from every place are all in the same room discussing and being completely, totally transparent about quality, service, finance, etc. At those meetings are primarily taken up by one facility or another displaying the things that didn't go right last month. The complaint numbers, the sentinel event that might have occurred, the baby that might have died, the person who may have spent way too much time in the emergency department and couldn't get upstairs, the number of calls that come into our ambulatory sites and our physicians that were not accepted within a certain period of time, because we have metrics for all of these. the appointments that people were not able to meet, or the patients were not able to get appointments. These metrics are discussed openly in meetings much bigger than this one, and they go on for a number of hours once a month. That's just one of the meetings, but it's all interdisciplinary. I have always rejected the notion that the responsibility for clinical care is just the responsibility of the clinical leader, the doc. It is the responsibility of everybody. And by the way, the compensation of each is, as I mentioned at the beginning, is tied to meeting those performance metrics. So all of them, the performance metrics tied to their compensation, is the same for everybody. And that brings everybody together. The fourth point is on employee investment. We make an extraordinary investment in employees. We have what's known as the Center for Learning and Innovation, which is the equivalent of a corporate university within our organization, which we started well over 10 years ago. That whole entity is responsible for the onboarding of new staff, the selection of new staff. We have a course catalog of courses, just like the course catalog of almost any university. Last year, 24,000 of our employees went through training. This includes training at every level. Much of it is mandatory. If you want to work in the peri-op area or in the emergency area, you're a nurse, you go through special training. We use Six Sigma, Lean, Capstone. We have industrial engineers. We have black belts. We make extensive use of simulation. We have one of the largest simulation training programs in the United States. We have 19 simulation rooms in a 40,000 square foot facility. The clinical leaders, administrative leaders, nursing leaders, and all staff, they can mimic almost any circumstance that goes on in any part of the organization, and it's done in a simulation format, just the very same as pilots are trained to fly planes. So if something happens, the cardiologists use it, for example, the OB staff use it, where they can run scenarios of what would happen in a case where a baby may have a very, very bad result. You don't see that result very often, and everybody is trained on those things that may happen very rarely, so that if it ever does happen, we know what it looks like. And if there is a sentinel event where a baby does have a bad result because of something that didn't go right, that is taken to the simulation center and it's replayed, and so that everybody, the whole team is there. This is in many ways an extraordinary asset that we have. I never ever thought that all of our clinical staff would buy into this as much as they have. And it's not just the newer clinical staff, it's in many of our elder clinical staff that have been around a long time who spend extraordinary amounts of time in the simulation center. And we also have a bioskills education center where people can do procedures on cadaveric specimens. We also have, as the point was yesterday, it was discussed in one of the panels about how you select new leaders. We have a major high potential training program, a preparation program. We have a talent pipeline. So we identify every year 100 people that we believe have future potential to be leaders in the healthcare system. They're put into a two-year training program. I now have 485 people in that list. So when I have an opening, or I need to make changes in management someplace, or we take on a new hospital and I need to replace the management like I did at Lenox Hill Hospital in New York City. Some of you may be familiar with Lenox Hill Hospital. When we took it over, once a very, very famous place, still has a great reputation, but ran into some severe difficulty. We took it over. I replaced all the management within the first 3 months, top to bottom, because they were catatonic. They couldn't get out of their own way. And that included the clinical leadership, including some of the top clinical leaders, as well as the top CEOs and all of them. But I was able to move all of those out, because if you want to change the place, sometimes you have to change the people. And so, I know in certain cultures that seems like a very difficult thing to do. It's not something you do all the time. It's not something you get up in the morning and say, boy, I love to do this. You should never like doing it. But when you have to do it, you have to do it. In that case, when we removed all the people out, I was able to go back to my high potential list, pick 7 or 8 people out of that list, move them into that hospital. We had trained them for 5 or 6 years. They knew our culture. They knew exactly what was expected. They knew the metrics. Plugged right in. 2 years ago, that hospital was in really bad shape. This year, it is getting extremely successful. And that's only after a 2-year period of time. And I could spend a lot more time on the employee investment piece, but I spend well over $120 million a year investing in employees. And I personally teach. All my senior leadership teaches. All my senior leadership do patient rounds every Friday morning. That includes my finance people, my IT people, my construction people. They all do patient rounds every Friday morning. They talk to patients. We meet with patients as part of patient engagement. That was a question we just asked a few minutes ago. This is an ongoing process. I mean, it doesn't even have to be, nobody even has to suggest that we do these things anymore. It just happens. Next point, which is something I kind of alluded to a second ago, is that you have to have the right people in the right places. If you don't put the right people in the right places and you don't spend a lot of time picking the right people, then a lot of things just won't work. It's not picking the people with all the degrees or picking the people with all of the wonderful academic background. You're picking the people with the right attitude, right motivation, right passion, can-do attitude. Nothing is going to throw them off their game. Pressures, budget cuts, over-regulation, that's not going to throw you off. You're going to do what you have to do to provide the best product and deliver the best service that you possibly can. Those are the kind of people. It's like I tell my staff, always pick the people where the light bulb is 100 watt, not the people where it is 60 watt or 5%. You know, some of them have the 5% is burning in there. Those people got to go. In our health system, nobody who's in a leadership position, nobody that was in a leadership position 10 years ago is there today. They're all new. And these are people we've trained internally. We know them. But this whole area is an extraordinarily investment of time. The next point I want to make is just don't think hospital. I kind of alluded to this. We have to be thinking as we go forward what we mean by a hospital. What is it? How do we define it? What should be in it? What shouldn't be in it? What alternatives do we create instead of having a traditional hospital? I think that is a major, major question for leadership. And I would hope that we would get at some point and not even use the word at all. It's a facility where health services are provided. Hospitals will be a smaller part of our health system in the future, as I mentioned earlier. We promote maximum transparency. Everything is pretty much known every place. Any one hospital knows about other hospitals. Everybody knows about the metrics every place. One hospital CEO can tell you about the metrics in the other hospital. Hospitals help themselves when they have all of that transparency. They understand the issues. They work as part of a team. You've selected the right people. They begin to help each other solve a lot of the problems that come up all the time. And the other lesson I've learned over the years is that we need to adapt the goal. We need to be able to think health promotion and not just illness treatment. This, of course, requires the development of new metrics. We should not just be in the illness treatment business. And when you get into this kind of a role, the role of the MD becomes less in some cases. Because now you have to bring in the social services components, which we have, as well as behavioral health, substance abuse, drug abuse, etc. The medical component may not be the dominant component of what it is you should be doing in those situations if you're in the business of just promoting health. And I would argue that in many cases, just in the regular delivery of care within a hospital, the MD is part of a team. It's not the sole person involved. And lastly, 2 last points here is that I believe in acting and not waiting for regulators. Now, we have regulation. I don't want you to misunderstand. We have regulation. We have federal regulation, state regulation, some local regulation. It's different than here in the UK, I think. But we're much less regulated. I have much more freedom to do things, I believe, than from what I anticipated in listening to the discussion here the last 2 days. But the regulators have to understand that they cannot be micromanaging. I was a regulator. I was in government. The biggest mistake of regulators think that they can micromanage from afar. Just makes no sense. You know, most of the stuff they do looks like when you're on the ground floor trying to do the right thing, it seems like it's just ridiculous. Sometimes if you have so much regulation, you feel like you're playing a soccer game, but you have 20 referees, and everybody's having different rules of the game. And I believe that the regulators should allow for competition. I'm a believer in competition. I believe the government has a role. I believe it sets the goals, it sets the basic rules, and then basically should get out of the way. And come in if something is not right, if something isn't going correctly, once the expectations are set and everybody knows what the expectations are. And last point is that I'm a strong believer that we have to dramatically change the payment system. I want to move away from fee-for-service payment. I want to move to complete risk. I want to go to total capitation and global payment. I do not believe that we can succeed in doing what we need to succeed given all the misaligned incentives that are inherent in a fee-for-service system. So what we're doing at the moment is that we are building the infrastructure in our health system and hiring all of the appropriate staff and building the right systems to be able to take full risk contracts. Now, we take risk today, but it's not a huge part of us. We have about $300 million in risk. We are an insurance company for our own employees because all of our own employees we're self-insured. So we pay for the cost of all of our own employees. And we've had dramatic success in figuring out how to dramatically lower the cost and improve the health outcomes of our employees. Our healthcare costs from last year to this year for our employees is going up 1.7%, whereas the trajectory over the last number of years was 6 to 8%. It's gone dramatically down because of a lot of things that we've built in and the programs we put in place for our employees. So we're building a major risk infrastructure. I want to be able to partner with insurance companies. I want to be able to go to insurance companies and say, I want to take 85% of the premium, 80% of the premium, 90% of the premium. I'll be at risk for that population of people that you're covered. Since I have all of the pieces of the continuum of care, I'm in a much better position to do this. We have a very good relationship. I know that Mr. Stevens, I believe, is here from United. We have a very good working relationship with United Health. But I also am getting my own insurance license because I want my ability to be my own insurance entity also. And I want to be able to go to, and I will have an insurance license, hopefully by the end of this year. And I want to be able to go to all of the employers in our area and basically say, I will take responsibility for the population of people who work for you. And I'll do it for a certain price. We set the clinical outcome goals and the quality goals and the service goals and the financial metrics, whatever you want, and then we will manage that care. That means, of course, that you have to be able to build a huge different level of competency than you would have in a traditional healthcare system. You cannot take people out of hospitals and have them do the insurance business. You have to hire them separately and hire different kinds of people, which we're currently doing. In fact, you're mentioning United. We've actually hired a number of executives out of United. I'm not sure that makes them too happy. But we work very cooperatively with United. We do have a joint product on the market with United at the moment. So we do a joint offering with United. So at the end of the day, long term, what I want to be able to be is I want to be able to take full risk. I don't think you'll ever completely eliminate fee-for-service, but I want the bulk of my business in full risk global payment capitation. That will drive the incentive for me to be in the business of health promotion as well as illness treatment. And when you put me at risk, I will tell you the 40% of people who are in a hospital, who are inappropriately there, who should be in another location of care, that will change pretty fast. Because if I put them into the hospital inappropriately, I lose my shirt. Remember, I'm held accountable for my financial outcomes. Wall Street watches what I do all the time. We're a not-for-profit private entity. But Wall Street treats me as if I was a regular for-profit anyway. They oversee all of my metrics all the time. So I want to be able to take full control, do population health, provide the full panoply of services. That includes the social care type of services as well. and then have the full continuum, the insurance side, change payment system, ambulatory, home, acute, long-term care, and all of the social care alliances, and have the whole thing and be held accountable for it. And lastly, let me finish. This is, in my view, it's about, in many ways, leadership. When I listen to some of the discussion here about who's responsible for what might happen at some hospital or another, I sit there thinking, the person who runs that hospital is responsible. The doc, the administrator, the nurse is responsible. That's their job. That happens in a place there. These people should not be there much longer. It is not, other people can regulate, but the responsibility sits right there. And I serve at the pleasure of my board. And if we don't produce, I'm not around. And I love it this way. I enjoy it. I love the competitive nature of it. I love challenge. I love to be able to try to do new things all the time. I love breaking the rules. I love asking for forgiveness, not necessarily always permission. But remember that, leadership, in my view, it's about having an extremely positive attitude. It's about being upbeat. It's about taking risk. It's about being can-do. You can achieve. You can get it done, which I believe we can get more done today than ever before, despite the austerity, which is occurring in the US and here. And it's important to remember that we're influenced by outside events, but we're not necessarily defined by them. We're not controlled by them. And we should also remember, if we look through history, the creativity thrives during periods of constraint. In every period when the most innovations occur, when your back is to the wall and you're forced to think very differently about the way things should be done. And this business is complicated, but we overcomplicate it. You've got to try to simplify. Our job is to provide the best services to the people that we are responsibility to serve. And I also believe that leadership is about looking from the outside in, not from the inside out. What I mean by that is look at it from the customer's point of view. Because I believe we're a customer service business. We treat patients, but you're also responsible for the needs of the community. So you're in the customer service business. I look at every patient and patient's family and a person who visits the hospital as a customer. How am I treating the customer? How does the customer see us? And as John Gardner, who was head of Common Cause, once said, that what we have before us are breathtaking opportunities disguised as insoluble problems. And that's the way I believe leadership should look at it. I believe it is not management. Leadership, in my view, is different than management. I believe leadership is the leaders are the people who want to force change and drive change. Look out, don't look down, look out and see where it is you want to go. And it's quite frankly all about managing the present. As somebody said, it's about managing the present, selectively forgetting the past, and creating the future. And if we don't do it, somebody else will. And they won't do it as well as we can. Thank you very much.
The timetable running up against, particularly with other people coming later on, means we've only got time for one or two questions, and I was going to take chair's sort of privilege and ask one myself, but has anyone got a burning question they want to ask, but it's got to be short or I'll cut people off?
Well, I purposely went long so the questions would be short.
Yeah, I know, that was your strategy. But my first question while the microphones are getting into position is, over here the argument against integrated care is the hospitals will swallow all the money up. What would you say to those critics?
I would say that I don't think that I would agree with that at all. If you change the payment system, when you have a changed payment system, if the hospitals swallow up all the money, you lose everything. So there's, I believe, an integrated care, and you can do it without having a changed payment system if you put the right leadership in the right places, who have the right motivation, who understand the overall goals of what it is we're all about. I don't think that occurs at all. We run a fee-for-service payment system in our place for the last number of years, yet I have the biggest expansion in our health system has been on the ambulatory outpatient non-hospital side, even though I make more money if I have people in hospitals. But I don't believe it's the right thing, and so I have moved services out. And that sets me up to be able to accommodate a new payment system, and this is the reason also that you look long-term. I believe integrated care is the only way to go. It is very, very hard to argue that you should be managing people through the continuum of care if you don't have responsibility for the continuum of care. I just don't know how you do it.